and cardiac surgery. So we'll be starting with the CBS, which is the computer based scenario. We have already shared the questions with our registered candidates, but yes, I will be sharing the question first and the suggested answers. And the answers would not be straight the questions that we are actually making it one liner. Rather, I would try to also discuss some of the concepts that would make you understand why the examiners choose this type of domains in the cardiology. So it won't be explaining the full concept because it won't be possible to discuss for 4 hours or 5 hours, but rather I would be trying to finish in next 2 hours or 2.5 hours. I would know definitely the high yield topics and domains in cardiology that would be asked. There is a separate domain, cardiac surgery, that would be taken by Dr. Sananta next week. So I would not touch base with that part. Rather, I would restrict myself to the cardiology. I would request all of you and also expect that those candidates who are preparing to like make their own question banks based on the discussions that we'll have today, because there would be many the domains, high domains that will be coming across. And revise is the smart way to get success. And we'll be also putting some atypical difficult questions. Why I have put the last line? Because in last few years we have come to know that the edict part 2 is not very much straightforward that it was before 3 4 years. So now they are putting some or other, almost I would say 25% of questions that is really difficult to know or answer in that 1.5 hour to 2 hours. So that's why we should prepare also. So as everybody knows or they understand, believe it is better to sweat in peace than bleed in war. And I believe this is the time when we can dare to or take the risk of sweating. So the first question that I asked in the CBS, it is related to, I would first explain and show you the domain from which I am trying to put the question. You are all free to share your questions in the chat box. I would request our the experts and also the examiners to address those questions, and also in between, if you want to put some clinical pearls to our candidates, I would be pausing and they can just talk to the candidates. It should be very interactive, so please be engaged, all the attendees. So the question comes like this: a 58-year-old man with no previous comorbidities presents to the emergency department with chest pain. The EKG demonstrates ST elevation in leads 2, 3, and AVF. Vital signs show heart rate of 56 beats per minute, blood pressure 75 by 55, with saturation of 96% on room air. Bedside echo done in the emergency department reveals right ventricular dilatation and right ventricular dysfunction. The patient is intubated straightforward, started on mechanical ventilation. Despite increasing the dobutamine and epinephrine doses, the patient has ongoing cardiogenic shock with rising lactate levels and decreasing urine output. What is the next big step in the management of this patient, and what is the rationale behind your management? So this is a question which is due to the ongoing cardiogenic shock happening in the patient, and you have done the basic management, the preliminary management that you are expected. You have evaluated the patient. Now the question would be, I would focus on the first question: what is the next best step? It is not the next step. So try to understand the language the examiner is actually asking, and what is the rationale of your management. Now, before going to the answer, I am dealing here with right-sided cardiogenic shock and failing inotropic support. Am I clear in my conflict right now, the explanation? And for that, the next best step would be mechanical circulatory support. So this is the examiner right now of this question tries to find the answer from the attendees or the examiners. So the next best step or the mechanical circulatory support that is available at this point of time in the intensive care unit: IABP, Impella, VV ECMO, VA ECMO, right-sided ventricular assist device. So these would be the 5 options that would be coming to my mind if I am getting the question that I have mentioned in the last slide, because it is right-sided cardiogenic shock with failing inotropic support. Now, I would exclude one by one and I will tell you the correct answer. IABP or an Impella are viable options for the left ventricular failure. So I am not dealing with left ventricular failure here. VV ECMO, yes, it is also a viable option, but it offers respiratory support, but not hemodynamic support. Durable right ventricular assist device is at this point of time is much more invasive and would be premature, given that if I would be managing the patient well with the appropriate support, the RV function may improve. So at this point of time, I'm not very keen to put the patient or take the decision for the durable right ventricular assist device. Now, the last one, which is right now for me, is VA ECMO. I think that solves the problem by draining the venous blood from the right side of the heart. Where is the problem? And that would be infusing into the arterial circulation that bypasses the heart as well as the lung, and that will be providing both pulmonary and cardiac support. So this question is a very important domain in the cardiology that comes from the cardiogenic shock, that will also asking the mechanical circulatory system support at this point of time. So you all need to understand the concept behind the mechanical circulatory support assist devices, as well as the different definitions of cardiogenic shock and what we are trying to answer. Dr. Ramanathan, yeah, please.
Yeah, thanks, Tapas. I think, I was jotting down some of the important um, topics that are clearly, tailor-made for exams. And I think you nailed it straight away by starting with the question on cardiogenic shock, because this subject is very topical nowadays. Of all the shock states, cardiogenic shock and septic shock questions appear the most in exams, most of the exams, followed by questions on obstructive shock. That's mostly, tamponade related. These are the 3 favorite shock questions that get asked. Now, of the cardiogenic shock template, you've chosen a particular limb of that algorithm. In fact, you've chosen the mechanical cardiac support
Yes.
limb of that algorithm, which needs to be followed. And essentially, again, it's a hot topic now. There are about 3 or 4 review articles that has appeared in the last 1 month in intensive care medicine as well as in critical care. And I would suggest all the exam going people to read those articles. The one from Alain Combs last week in critical care gives you an algorithm to the management of cardiogenic shock and mechanical cardiac support devices. Now, this is only one limb of that algorithm.
Yes.
This can be diverted anywhere. So the cardiogenic shock per se can then be looked at in terms of stratification, SCAI classification, and these are not just the cardiologist perspective that you are looking for. These are important for intensivists who manage cardiogenic shock as well. So that's one subset of questions that you can expect in this domain. The second subset of questions which you can expect in this domain, apart from, say, MCS devices as well as stratification, would be the use of inotropes and the various inotropes in this setting. So you've already said this as part of your STEM. So, they can go deeper into that, asking for comparison between inotropes, inodilators, newer inodilators, and all those stuff. So again, it's another stem of the same question where questions are very popular. The last thing that can happen as part of cardiogenic shock, especially in the context of MI, would be going into complications of MI, say something like mitral regurg or VSD here, and then going along that pathway. So if you look at that entire spectrum of questions, so again, with just one stem, you can clearly see. And one thing I really like, Tapas, when you started off, is we are only just providing a template. There are more questions and more,
Yes.
there's things that can be stems that can be really be made out of this big title. So out of the cardiogenic shock title, you can have questions on MCS, you can have questions on specific stratification, questions on inotropes, questions on arrhythmias, questions on complications, which can be different stems under the same umbrella. So yeah, I mean, look, I think these are, I mean, the specifics of your question, I liked it, but I was just trying to allude to some of the big stems that can arise from this title on cardiogenic shock.
Sir, as you have rightly told, I have in the CBS also 3 complications, one related to MI, which has resulted in cardiogenic shock. So I'll be discussing that also in due course of time. So there are like 21 questions. Out of that, cardiogenic shock has 4 questions. So this is just the one question.
Okay.
So, okay. So next question, the domain, it's again a very high yield domain. It is ACLS rhythm, cardiac arrest, and ECG. So you got a call to see a patient on the ward who has a return of spontaneous circulation, ROSC, following a cardiac arrest. The patient is groaning. On initial assessment, you find patent airway, bilateral equal chest movement with good air entry, respiratory rate 18 breaths per minute, SpO2 94% on high flow oxygen. Heart rate is 45 per minute regular, poor pulse volume, BP of 57 by 30 millimeter mercury. Conscious but not fully alert, and RBS is in the higher range of normal. ECG done, which showed this one. So already the question has been attempted by many in the examination done before. So the questions right now in this, what is the ECG rhythm? Diagnosis, immediate treatment. So you can see again the question, post ROSC. This is heart rate of 45 per minute, poor pulse volume, BP 57 by 30. And this is the ECG. So I would straightforward go to the answer. It is right now I'm dealing with complete heart block. The complete diagnosis would be post cardiac arrest status, complete heart block, again cardiogenic shock. And the immediate treatment for me at this time, as patient is, though the blood pressure is very low and heart rate is 45 per minute, but it is still right now maybe perfusing due to the junctional rhythm. And it is the treatment would be injection atropine to start with, maximum up to 3 milligram, injection isoprenaline, injection adrenaline, fluid resuscitation. I don't know what will be the result of fluid resuscitation, but yes, and transvenous spacing or transcutaneous spacing are the immediate management. If I would be now going with the answer, this is the immediate treatment that I need to do. And this is the question. So anything at this point of time, or I'll go to the next question.
Looks good, Tapas. I mean, the only thing I thought, I mean, I know you have already given it in the question. Otherwise, I would have tweaked my answer to question C as ABC followed by injection atropine, isoprenaline, adrenaline, fluid resuscitation.
Yeah.
Because that's a standard answer every examiner expects.
Yeah.
The ABC should come first. But you've already mentioned in your question itself that airway is patent and he's breathing
Yes.
properly or something. Yeah.
Yeah. So just adding to this question. So this is a very important article I got just recently published in 2023. The type of post cardiac arrest rhythm should not be labeled. So the meaning or the explanation in this article, that when we are getting ROSC, so we will be focusing on whether my patient is having the hypotension, systolic blood pressure less than 90. And at that point of my focus of resuscitation should be to improvise the hypotension. So I would be starting with IV fluid bolus, and then I would be seeing whether right now the BP is improving. So if it is improving, then I would be measuring maybe starting with the post cardiac arrest care at that point of time. Now, if still after the fluid resuscitation, but the hypotension is persisting. So I would be starting with vasopressor or inotropic agent that we all do. And then I will see the heart rate. So if it is less than 50, so I would be starting with some maybe the chronotropic agents. And if it is more than 150, so infusion or adrenaline or phenylephrine titrating to the blood pressure. So the whole idea of this algorithm is at the point of ROSC in the emergency situation, I'm not going to label which rhythm I am dealing with. Rather, it should be to start or continue with the perfusion to the end organs. So that should be the immediate management at the appropriate time. Now, some of the ECG features of complete heart block: severe bradycardia due to absence of AV conduction, and the ECG would be demonstrating complete AV dissociation with atria is the beating at its own rate and ventricle is beating at its own rate. So it is AV dissociation, and as you can see here, so these are atrial rates 100 beats per minute and ventricular rate is only 40 per minute. So the ECG, typical complete heart block ECG. So there would be almost 7 or 8 questions based on the ECG, and cardiology is all about the first thing would be ECG interpretation, and you would get it in a different scenarios. It's not that it will be only related to the ECG diagnosis, but there would be the questions coming after the ECG interpretation. Now, the perfusing rhythm is maintained by junctional, as I have told. Maybe in the previous patient that I have discussed, maybe it is the patient is conscious, airways pattern, maybe due to junctional or ventricular escape rhythm. And alternatively, the patient may suffer ventricular standstill leading to syncope or sudden cardiac death if we are unable to resuscitate the patient in the right way. And some of the high yield ECG rhythms that is a favorite topic in any of the critical exit exam. So we have divided into the ECG patterns normally asked: arrhythmias or peri-arrest arrhythmias or rhythms, and heart block. So this is one domain. So you need to make your own question bank and start like putting the questions on ECG rhythm so that you can revise it well. And in this, it can be atrial fibrillation, atrial flutter with or without variable block, second, third degree heart block, fascicular block, VF, VT, the post cardiac arrest rhythms, digoxin effect, RMT, ECG, degenerating into the VF. Now, the second important domain in the ECG is the ischemic rhythm. And in the ischemic rhythm, we all know it is MI related. So MI and MI complications. And the last one, which we discussed in our previous course, 2 days before only, and the examination also asked about the posterior MI and the complication. So this is a very high yield topic. Now, the third domain would be in the ECG, metabolic rhythms, all related to potassium, calcium, magnesium, TCA toxicity, digoxin toxicity, hypothermia. So all these questions can be asked in the ECG rhythm. Fourth one is the temporary pacemaker rhythms, whether it is ineffective capture or like inability to sense, inability to pace, whether it is the VVT pacing, DDT pacing, so pacemaker fractures, all these things that can be asked. Now, the fifth one, which is the last one, if you are excluding all these things, it would be related to some syndrome, whether it is Valenciennes, Brugada syndrome, then short and long QT syndrome, torsades pointers, WPD, WPW syndrome, fat embolism, pulmonary embolism, pericardial effusion, dextrocardia. So this would be the ECG patterns that you need to revise well and make your concepts clear. Now, the third question is pulmonary embolism focus. So the domain is related to pulmonary embolism. A 55-year-old man with poorly controlled type 2 diabetes was admitted to the medicine floor with a 1-week history of worsening leg diabetic ulcer despite oral antibiotics. His vitals on admission were temperature 38.4 degree, heart rate 110, BP 100/60, respiratory rate 20, SpO2 95% on room air. His left leg is swollen and tender with an distal ulcer. He was now on elevated at 3.4 milligram deciliter. Now the repeat vitals, heart rate 120, BP has worsened further to 88 by 59. Respiratory rate is now 28 and saturation has actually dipped 90% on 4-liter oxygen. He is transferred to the ICU and unfortunately he becomes more hypoxic. He is intubated, started on Norepinephrine 0.3 mics for persistent hypotension post intubation. POCUS is performed and it shows long sliding on both sides and bedside transthoracic echocardiogram done that showed this picture. So very straightforward question. I'm not trying to make it lengthy because we have almost long question, the 21 questions to discuss. So the diagnosis and the further management. So the patient has been ill for 2 weeks. Just I'm trying to scan the question, and the reason why I have made the questions all those red color. Whenever you get the questions in your mind, you can just make the important the vitals or the points that each actually need to be considered. Rather than all these lines are not very important for me. So that's why I have tried to make it in my mental side fixed, or I would be just reviewing this again and again before answering the question. Now, so this is a case where the patient has been ill for 2 weeks, left leg swollen, develops tachycardia with increasing vasopressors, and patient is right now on the high dose of vasopressors. Patient's presentation based on the clinical examination, pre-test probability testing based on the Wells criteria with elevated score, and the echocardiogram finding that has been shown in the last slide is most consistent with the acute massive pulmonary embolism. And the echocardiogram shows signs of RV pressure and volume overload. Now, here, pulmonary embolism is classified massive when you are getting the hemodynamics to be very unstable, systolic blood pressure less than 90, or drop in the systolic blood pressure more than equal to 40 millimeter mercury without other etiologies. And thrombolytic therapy is indicated if there are no contraindications. Although somebody may be saying that I will start with maybe some more fluid, but if they would be arguing for the sepsis part, but his echocardiogram shows RV strain and septal displacement in the left ventricle. So if you are going for IV fluid administration at this point of time more, that could impair the left ventricular filling by causing more displacement of the septum and further decrease in the LV size and compliance. So it would not be the next best step, rather thrombolytic therapy, which is a definitive treatment at this point of time. Now, question number 4. Again, it's straightforward question. 34-year-old male is found unresponsive. ECG obtained by the EMT team is below. Already it is marked the problem in the ECG. So ECG findings and diagnosis and management. So this is the answer, push and pull effect. I have tried to summarize by this picture, very well mentioned in the life in the first lane. Push and pull, hypokalemia, it is push, T wave inversion, ST depression, and prominent U wave. And I am dealing in my question, this one, same one. So it is hypokalemia. And the pull is hyperkalemia, peaked T wave flattening, PR prolongation, and wide QRS complex. So this is the answer. If you know it, this is a cakewalk. So hypokalemia, what are the ECG findings? Prolonged PR interval, ST depression, and U wave. Positive deflections typically seen in the VT2, V2 to V4. And you can see in our also V2, V3, and V4. So these are the main leads where you will get the ST wave inversion. And hyperkalemia, if somebody is confused, I have already explained pull effect. So you will not get the typical push effects. Hypocalcemia, it would be prolonged QT interval. Hypercalcemia, shortened QT interval. Hypermagnesemia, similar to hyperkalemia, so pull effect. And the treatment would be KCl infusion, injection magnesium sulfate if it is refractory hypokalemia, and other stuff I'm not going into detail. Severe symptomatic hypokalemia, continuous ECG monitoring is required and frequent potassium estimation. Never give KCL directly IV, and rapid IV correction can lead to dangerous hyperkalemia. Always use isotonic saline to like dilute or like give it with the KCL. Do not mix with the dextrose containing solutions. Now, question number 5, pacemaker, another important domain in the cardiology. A 75-year-old patient with ischemic heart disease has been admitted to hospital with recurrent syncopal episodes. Clue number 1, CT shows moderate biventricular dysfunction and cardiac angiography demonstrates a chronically occluded right coronary artery with diffuse coronary disease. The drug history is bisoprolol, ramipril, spironolactone, and furosemide. Temporary pacing wire is inserted, and this is the ECG that you are getting. Okay. So the questions are here. How could you describe the temporary pacing wares using the first 3 positions of the British Pacing and Electrophysiology Group generic pacemaker code with reference to the pacemaker functionality? What is rate modulation and what actions should be taken when defibrillating a patient with permanent pacemaker? So there are 3 the segments in this question. So the nomenclature, the things that you need to know. So VBI, VOO. VBI is demand pacing. So first one is the paced ventricle, sensed ventricle, and the third one is inhibited if your native activity is sensed. So if it is like already like the native activity is there, so it would be inhibiting. Now VOO is for fixed asynchronous pacing. So paced ventricle, no sensing. So that's why it is O. Now, the second question is what is rate modulation? Rate modulation is ability of the pacemaker to alter the rate based on the physiologic demand. So the pacemaker will be modulating the heart rate based on the demand. Now, the third one, which is again very important and related to the cardiac arrest protocol, the SCLS protocol. If you are defibrillating in a patient with a permanent pacemaker, what are the precautions or the monitoring that you need to do? That is a very favorite questions from the examiners. The defibrillator pads should be placed as far as from the pacing box possible. This is point number 1. And the second point is pacemaker must be checked as soon as possible post defibrillation to check the pacemaker settings and functionality. So these are the 2 things that you need to remember. Now, there are certain important things that I want to discuss here or show to you. Types of pacemaker, I'm not going to detail. It is single chamber, dual chamber, biventricular pacemakers. So biventricular pacemaker are mainly used in the CRT, cardiac resynchronization therapy. Now, pacing and sensing, there will be like the nomenclature is the 1, 2, 3, 4. So it is universal. The first one is chamber paced, second one is chamber sensed, third one is response to the sensing, and the fourth one is rate adaptive. So you have to remember the pace, sense, response, and adaptiveness. These are the 4 things that you need to remember. And if you will be discussing the single chamber modes and the multi-chamber modes, so these are the some of the classification. Again, you need to remember, you need to clear your concepts related to pacemaker. It is a very important domain, not able to discuss in maybe 2-3 minutes. And the different tracking modes. Tracking mode is DDD. So pacing in the atrium and ventricle, sensing in the atrium and ventricle, and the third one is inhibit and or trigger. So this is something related to pacemaker. We would be sharing, I have already said in our the resources related to pacemaker, and it would be again discussed in the cardiothoracic surgery as well. Now, the question number 6, again very important domain, Takotsubo cardiomyopathy, and there are 2-3 other questions also related to that. A 51-year-old woman presents after a fall with a resultant left femoral neck fracture. The patient has no prior medical history and lives independently. While awaiting surgical repair, the patient complains of chest pain. An EKG is non-revealing. However, When you did the echocardiogram, it demonstrates dilated LV with an ejection fraction of mere 25%. Now the patient undergoes a left heart catheterization with a left ventriculogram. You are in the cath lab and the cardiologist is showing you the left ventriculogram. So this is the picture when he is doing the left heart catheterization. And you did the focus at that point of time also, and this is the finding you are getting in the IVC as well as in the apical four chamber view. What is happening? So the questions are most probable diagnosis, management. So it's a straightforward, already given so many clues. The patient is presenting with cardiac symptoms and reduced left ventricular ejection fraction in the setting of a stressful event. The left ventriculogram shows classic LV apical ballooning. These findings are suggestive of stress cardiomyopathy and also named as Takotsubo cardiomyopathy, broken heart syndrome. So there are like I think 10 nomenclatures for this specific the problem. And the confirmatory is normal coronary catheterization. That would be excluding the other like the cardiac problem as such. The disease is self-limited with LV function typically improving with the supportive therapy. And stress cardiopathy is most common among the post-menopausal women. And she's a 51-year-old man, lives independently and had a fall. So there are many stressful events that is happening. So there are the acute vascular management in the setting of Takotsubo cardiomyopathy. You have to take care of the failure component. You have to take care of the arrhythmias. You have to take care of the thromboembolism. You have to take care of also the long-term management and also follow-up management in the patient with Takotsubo cardiomyopathy. There is another like terminology atypical Takotsubo cardiomyopathy. That is again another question. We will be talking about that in our CCS. Now, the seventh question is pharmacotherapy related to cardiology, renal and cardiac involvement together, and ECG. A 62-year-old woman has been admitted to the ICU with hypotension and bradycardia following a 4-day diarrheal illness with vomiting. She is in acute renal failure with a serum potassium level of 6.9 millimole per liter. Her medication history is unknown and her ECG has been done, which is like this. So renal failure, hypotension, bradycardia following acute gastroenteritis, and medication history we do not know. What abnormalities are shown on the ECG? What is the most likely cause of the bradycardia? So the answers here I am dealing with all types of, I would say, multiple problems in the ECG. Ventricular bradycardia, atrial tachycardia, AV block, and reverse tick ST segment changes. I would show you what is this reverse tick ST segment changes. If you will get the reverse tick ST segment changes, maybe the patient is having digoxin, and due to the acute gastroenteritis, now the patient is resulted in acute renal failure, and the normal digoxin level in the body has landed up in, maybe I would say, is getting the digoxin toxicity. So the ECG is mainly due to the digoxin toxicity. Now the classic digoxin toxic dysrhythmia combines supraventricular tachycardia, slow ventricular response, and PVC is the most common abnormality. You will get lots of ventricular bigeminy and trigeminy with sinus bradycardia. So all types of ECG rhythms can happen in the digoxin toxicity. That is normally bedside teaching by our teachers. So you will also get AF also and VT sometimes, polymorphic and bidirectional VT. And the digoxin toxicity effect on the ECG, downsloping ST segment depression with a characteristic reverse tick or Salvador Dali sagging appearance, flattened, inverted, or biphasic T wave and certain QT interval. It would look like this. Sagging ST segment that resembles reverse tick. You can see here. The tick is reversed here, and this would look like this. And the nomenclature is after the scientist or the cardiologist Salvador Dali sagging. The typical one like this. If you are getting this, so it would be suggesting more towards the digoxin toxicity. At this point of time, any inputs from Dr. Ramanathan or Dr. Sanant or anyone, or I would continue.
Yeah, I mean, as with digoxin, Tapas, I'm not sure whether you're. I know you put in a broad heading saying pharmacotherapy. I would think other antiarrhythmics are equally popular. So
Yes.
amiodarone, lignocaine, and procainamide are popular drugs that come under this.
Yes. Yes.
Also equally important are the classification of antiarrhythmic drugs. So, I mean, the moment you get into cardiovascular pharmacology, it's so vast. But given that you have spoken about digoxin, I thought, similar drug profiles of other antiarrhythmics, the candidates should be thorough for similar questions.
Yeah, agree. So amiodarone is a very favorite domain as talked by Dr. Ramanathan. So next question is pulmonary artery catheterization. Though it is not being used so rampantly as it used to be maybe 10, 15 years back, but I was going through one article recently published in the Chest Journal, and because I had a presentation on cardiogenic shock, and surprisingly, I got one paragraph on the revamping of the pulmonary artery catheterization in some of the recent studies, and they have found that if you are monitoring the refractory cardiogenic shock with pulmonary artery catheter in place, so the response, the interpretation is better. So maybe Dr. Ramanathan would be the best person to guide. But now that article was very something which came to my mind very I would say very promising. So what do you say?
Yeah, I mean,
Anything in your practice?
no, Tapas, that's making a comeback into cardiology these days. You need to understand that when we spoke about cardiogenic shock, the stratification of cardiogenic shock with SCAI classification, there are 2 or 3 hemodynamic variables which are mentioned, all of which need the PA catheter. The cardiac index, the pulmonary capillary wedge pressure, and I think there's one more, which is mentioned there. But the most important point about PA catheter and its resurgence in cardiology is in the management of cardiogenic shock. With the formation of cardiogenic shock teams in various hospitals, what is happening is patients with acute MI, as soon as they go to the cath lab, they have a right heart catheterization done with a PA catheter. And 2 important values are calculated. One is cardiac power output.
Yes.
The other one is pulmonary artery pulsatility index, PAPI, PAPI. Now, again, this is another domain which is upcoming, and it's a potential question in any competitive exam where they talk about CPO and PAPI and ask you to interpret it. So CPO is reflective of LV function. PAPI is representative of RV function or RV dysfunction. So a patient who has a deranged CPO, has isolated LV dysfunction, is a good candidate for Impella in the long run. A patient who's got a deranged PAPI alone or a deranged PAPI with a deranged CPO would be candidate for VA ECMO. So again, the choice of mechanical cardiac support devices eventually now falls back on how you interpret these values after putting in a PA catheter, and things are now getting more streamlined with the reintroduction of PA catheter and cardiogenic shock.
Completely agree. So that article is really interesting. Based on that PAPI, you will be deciding whether you have to go for the right-sided mechanical circulatory support, or you have to think about something else, the left-sided support. Yeah. So coming to the 8th question, a 68-year-old obese man with diabetes mellitus, hypertension, and coronary artery disease was admitted 5 days ago for an anterior STEMI. Coronary angiography was performed with a bare metal stent placed in a completely occluded left anterior descending artery. He was discharged yesterday, but was brought back to the ED today with altered mental status and severe dyspnea. Vitals are heart rate 120 beats per minute, BP 85 by 50, respiratory rate is high 27 per minute, saturation is 90% on 6 liter nasal cannula. A new loud, harsh, hollow systolic murmur is heard at the left lower sternal border. An EKG is unchanged compared to the EKG on the day of discharge. TT is attempted, but as the patient is very obese, so limited view due to the body habitus. Now, you decided to put the PA catheter and the following numbers are obtained. And when you are getting the wedge pressure, it is 25 millimeter mercury with V waves noted. Very classical and straightforward. If you are getting this in your exam, so it should be immediately coming to your mind what you are dealing with. Now, cause of the shock and the management. Now, as discussed in the first question by Dr. Ramanathan, this is one complication of MI. So that is ventricular septal rupture. And it typically occurs 3 to 5 days after an acute MI, but can occur as early as 24 hours, or it can like appear as late as 2 weeks after the anterior like acute MI. The frequency of septal rupture is equal in the anterior and the non-anterior infarctions, and the patients often present with sudden hemodynamic compromise. A loud, harsh, hollow systolic murmur is present over lower left and right sternal border, classical. And the most important, the statement that we got in the question itself, if you are putting the PA catheter, the numbers show a step up of the oxygen saturation between right atrium and right ventricular, indicative of a shunt at the ventricular level, because there is ventricular septal rupture in this case. So this is something I am dealing here in the pulmonary artery catheterization, that this patient is having ventricular septal rupture. Urgent surgical intervention, though this is associated with high mortality, is warranted in patients with cardiogenic shock. Initial stabilization, you have to start with vasodilators, inotropic agents, diuretics, and IABP. Delayed elective surgical repair may be feasible if your patient is having heart failure but no shock. There are also other mechanical complications, as rightly told by Dr. Ramanathan, papillary muscle rupture, acute MR. There are other mechanical complications of acute MI. They can also present with the systolic murmur, hemodynamic compromise, presence of V waves, but the step of the oxygen saturation would not be present. This is the question that I got in my EDIC 2 exam, which I appeared in Dublin. I would say 9. Right now, highlight here. Now, ninth question. A 52-year-old man has brought to the ER having been found collapsed next to a canal. He's dressed in multiple layers of cold, wet, and dirty clothing. So these are some of the clues the examiner is trying to give to you. Cold, wet, dirty clothing, brought to the ER, found collapsed for a long time. He has a heart rate of 48 beats per minute and BP of 88 by 54 millimeter mercury. GCS is 9. Paramedics have been unable to obtain a temperature reading. So many clues have been given in the 4 lines. ECG done short, and you are getting the ECG like this. So very classical. What abnormalities marked by the arrows? What are the causes for this type of waves? What changes are made to advance support algorithms when you are resuscitating a patient with hypothermia? So I am dealing with Osborne J wave. Also, there are like other causes apart from hypothermia, hypercalcemia, brain injury, subarachnoid hemorrhage, vasospastic angina, type 1 Brugada syndrome, and also sometimes it's a normal variant in the case of early repolarization. Now, there are certain changes that have been made when you are resuscitating a patient with the refractory hypothermia or severe hypothermia. No adrenaline or other drugs until you are getting the temperature more than 30 degrees centigrade, core temperature. Between 30 degrees centigrade and 35 degrees centigrade, double the dose intervals for the advanced life support drugs. Shock ventricular fibrillation if you are getting up to 3 times, but no further shocks until the temperature is more than 30 degrees centigrade. So there are obvious reasons why you do not want to give the dose of the other medications so frequently, because the metabolism is very slow in severe hypothermia. So there are certain clues I want to share here. I think everybody knows it, but you have to read it, make your concept clear. Reworm is the best antiarrhythmia and inotropic thing that you can do rather than adrenaline and so many other like the drugs that you are using. Look for and treat the comorbidities and consider alternative diagnosis. Anticipate that you are going to have a prolonged resuscitation, so you need to involve significant multi-specialties at that time, and the team members should be ready for a long resuscitation. There are certain key changes, defibrillation and pacing. I have already explained. You have to try up to 3 times, but after that, try to delay it until the temperature reaches 30 degrees centigrade. Pacing is generally ineffective. Do not try it unless bradycardia persists when you are getting the normothermia, because sinus bradycardia is a physiologic response and is not treated specifically. So you should not be only focusing for the bradycardia. Ventilation, normocapnia will be achieved at lower minute volumes than normal. So do not go for hyperventilation that risk the cerebral hypoxia, and aim for a normal CO2 on ABG, not corrected for the patient's temperature, because there is a correlation between the temperature and also all these gas values. Intubation in patients with perfusing rhythm, intubation may precipitate VF. So try to be gentle while you are doing the intubation in this type of patients. Resuscitation drugs, I have already told, they are normally often very ineffective and they would be having reduced metabolism. So these are withheld below 30 degrees centigrade, then given with twice the time interval between the doses until your temperature is approaching 35 degrees centigrade or circulation is restored. So adrenaline, just in a nutshell, I will be making it very simple. You will be giving it every 8 to 10 minutes once the core temperature is above 30 degrees centigrade. In other times, it would be 3 minutes or so. So, and your chest compression would be very difficult because muscular stiffness would be there. Reworming can be passive or active, but uh, you should try. If you are not getting the response or it is 30 degree, it should be active. Now, remove the wet clothing. Cardiopulmonary bypass is the most effective active internal reworming. So therapeutic maneuver of choice is cardiopulmonary bypass. So there are multiple ways how you should be going for the cardiopulmonary bypass, whether it is femoral or aortic right atrial bypass. And the temperature increases like 1 to 2 degrees centigrade every 5 minutes. That would be your target. And bypass should be instituted for patients in cardiac arrest, patients with hemodynamic instability, and core temperature below 30 degrees centigrade, frozen extremities, and you are getting rhabdomyolysis because of the refractory hypothermia and hyperkalemia that is causing your patient to be in the persistent or refractory cardiac arrest.
Tapas,
10th question.
We are moving more towards VA ECMO than cardiopulmonary bypass in these patients nowadays. There's a small change in paradigm, but then it's still catching up. A lot of institutions now move to VA ECMO because it can be instituted faster.
Right. Yeah. Yes. I agree.
But the concept remains the same.
Yeah. Exactly. Yeah. Thank you. So the next question related to again PSC, pulmonary artery catheterization. You are managing a patient with severe systolic heart failure and septic shock in your ICU while attempting to obtain a waist pressure. You see the following tracing after inflating 1 ml of air into the balloon. What is happening? So very tricky question. So if you know it, you will be just taking maybe 10 seconds to answer this. So what is the problem? The cause and next best step in the management. So it is overinflation and over wedging, I would say. So deflate the balloon and pull back to obtain a pulmonary artery tracing. So this should be your answer. The tracing demonstrates a continuous increase in the pressure. You can see here, continuously increasing the pressure here. And then when you are actually pulling it back, then you are getting again the waveform. Now, it's a continuous increase in the pressure with the balloon inflated that is consistent with an over-wedging position. And this can be due to eccentric inflation or the balloon being trapped against the vessel wall. And in this position, the pressure increases due to continuous flow of the flush fluid through the catheter tip. So this increases the risk of vessel rupture. Now, it is again one of the very good topic for your exam, not possible in 1 or 2 slides to explain, but these are some of the waveforms, very the preferred domain in the EDIC 1 as well. They will just put one question out of this in the MCQ based exam. And there are also some of the troubleshooting. What are the problems you can see? How to distinguish between RB and PAP waveform, catheter motion artifacts, under damping, over damping, and over wedging. So this was the question in the previous slide. So this is the over wedging. You will see sharp increase in the pressure. And when you are actually taking little bit pulling back, you will get the waveform again. So this is the classical question they can ask me. And this is something I got. This is a recent paper, 2022, contemporary pulmonary artery catheter. You will get most of the things for the exam purpose. Question number 11, another mechanical circulatory support, IABP. 61-year-old man with diabetes mellitus presents with chest pain and hypotension. During cardiac catheterization, left main disease is found and the patient is scheduled for CABG. Before transfer to the CCU, an intra-aortic balloon pump is placed. The waveform is shown below. Obviously, they would be asking out of the 4, 5, the permutation and combination. What is the problem? So the problem is inflation is occurring too late. So you have to adjust timing to ensure the inflation just prior to the dichrotic notch. I would be a little bit faster in our the discussions because there are a lot of questions right now left. And these are the 4 things that I want to highlight here. So just take this as an important note. Early inflation, late inflation, early deflation, late deflation. So the questions would be, what will be the physiologic effects? What will be the troubleshooting? And what would be the waveform characteristics? There would be only 2 to 3 permutation combinations. So easy to mark fetch, like if you know the concept well. 12th question is dealing with another complication in the cardiology, aortic dissection. A 56-year male chronic smoker with uncontrolled hypertension presented to the ER with acute onset chest pain radiating to the back. CT scan was done. Very classical, straightforward question. Identify the abnormality and the management. It is aortic dissection. We will be going first with the medical management, and based on the type of dissection, the level of dissection, we will be going for whether I would be opting for surgical management. So this is a algorithm. Suspected aortic dissection, initially you will be stabilizing, then go for the diagnostic imaging. You will be initially stabilizing for the blood pressure and the heart rate, adequate analgesia, then go for the transthoracic echo or transesophageal echo, CT. If patient is stable to be transferred, liaise with the surgical team. If it is type A dissection, where you are dealing with the ascending aorta, so surgical intervention. If it is type B, complicated or uncomplicated, maybe you can go ahead with the medical management. Complicated, so the right now the preferred choice is endovascular repair. So that would be something you need to remember. So there are many things. What are the complications that can happen in the aortic dissection? So that is a completely separate chapter. This is one article again I found very recently published, November 2023. Management of aortic dissection in the critical care. You can go through this in the Intensive Care Society. Now, question number 13. 45-year male admitted to the ER with acute onset chest pain and shortness of breath for 6 hours. ECG taken in ER. This is the ECG. What is the diagnosis? What is the definitive management? Answer is anterior wall MI, and straightforward the definitive management, the answer would be PCI. You need to be very thorough. take a the screenshot. What would be the area of infarction? So what would be the ECG leads involved and what would be the artery involved? So classical question, not going in detail. We have learned this from our MBBS days also. 14th, cardiac pharmacology. Again, another question. It inhibits phosphodiesterase 3 enzyme by decreasing cyclic AMP hydrolysis. It works as an inodilator. Which drug we are talking about? What is its effect on the right side of the heart? Answer is milrinone, and it improves contractility of the right ventricle by as a pulmonary vasodilator, where it reduces the afterload for the right heart, and also peripheral vasodilator, reducing the preload to the right ventricle. And also it has leuciotropy action. So milrinone, very important, as told by Dr. Ramanathan. You have to focus on, I think, 10 to 15 cardiac drugs that the examiner would be definitely expecting that you should know everything about that. So there are certain vasodilators: pulmonary, nitric oxide, milrinone, prostaglandin, sildenafil. So there are a lot of things that you need to remember. I'm just giving you the slide. Now, another question again related to cardiac pharmacology: protamine sulfate. What is the mechanism of action? Then what are the two important side effects? So mechanism of action, everybody knows protamine. It is a highly cationic peptide that binds to the heparin. So it is an antagonist of heparin overdose or low molecular heparin to form a stable ion pair which doesn't have any anticoagulation activity. And this complex is then removed and broken down by the reticuloendothelial system. And the complications, the side effects, anaphylactic is the most important. Pulmonary vasoconstriction resulting in pulmonary hypertension, bronchoconstriction, so all the constrictions. Bradycardia negatively impact the platelet function, interfere with the coagulation factor, and decrease the thrombin resulting in the fibrinolysis. 16 is one domain related to the medical part, that is infective endocarditis. So the question is, 70-year-old male presented with left side weakness of the body with right facial droop. He also has painful red raised lesions in the hand and feet, as shown in the picture. You can see here, which have been progressive for last 3 weeks, along with feeling unwell, low-grade fever, generalized malaise, and body ache. He was treated for the polymyalgia rheumatica by the local physician without much improvement. Now, on auscultation, you are getting a loud pansystolic murmur over the precordium. So this is the important, the thing that they want to share. Clue. So what are the skin lesions consistent with? What can be the other skin lesions or lesions associated with? What is your most probable diagnosis and the treatment plan? So what is shown in the picture is Osler's node. There are other lesions can be present: Genevieve's lesion, Roth spot. The most probable diagnosis is infective endocarditis. Treatment plan, it depends. It can be medical. Start with empiric antibiotic, benzathine penicillin, flucloxacin, gentamicin plus minus vancomycin. And also you can consider the surgical indications. If your patient is having heart failure, persistent infection, if you are having the embolic risk to be very high, so you have to go for the surgery at that time. As per the European Society of Cardiology as well as American College of Cardiology, so indications are, if you are getting aortic agitation more than 10 millimeter with severe stenosis or regurgitation, and as per the SCC or AHA guideline, so early surgery for left-sided mobile vegetation more than 10 millimeter without any relevant to the lesion severity or operative risk. And the fourth point would be prosthetic valve endocarditis. So if you are having any of these things and you are considering, you should go for early surgery for the infective endocarditis. Now 17, again one question related to ECG. I would be straightforward giving you the hint. 79-year-old female, past history of hypertension, started with hydrochlorothiazide and captopril and ketoconazole for vaginal thrush. C was also receiving digoxin 0.25 milligram. Allergic rhinitis and flu-like illness diagnosed, and you have started with non-sedating antihistamine. Now you will be getting the complaint from the patient of syncopal episodes and presented to the emergency department. In your clinical examination, you are seeing that patient is having a well perfused normotensive patient in the ER, but bursts of an irregular pulse were present like this. So what is happening? Classical ECG, it is Dorsadis D pointis and the treatment is IV magnesium. Now 18 ECG diagnosis and treatment, very classical. Routine investigation for insurance, always don't find that patient will be having abnormality or it would be pathological ECG. So for that reason, I just want to share one ECG. ECG for normal, like no, the checkup for the insurance, and you are getting the ECG, and this is something lead reversal. You can see classical lead 1, lead 2, lead 3. In that 1 and 2, you can see negative deflection. So nothing to be done at this point of time. Just change the leads to the correct position. Question number 19. Very interesting question. 20 years male, known carcinoid syndrome, presented with vomiting, shortness of breath, tachycardia, and palpitation. Multipara monitor revealed this one. So what is happening? What is the typical abnormal value that is catching my attention from this one? You can see the CBP waveforms. What is happening? Finding and intervention. So it is fusion of C and V wave, suggestive of TR, tricuspid regurgitation, associated with right-sided carcinoid in the heart. They have given you the clue, known carcinoid syndrome, and having all like the GI problems as well as breathing problems here. And this is the ECG multipara monitor. So you are getting the fusion of the C wave and the V wave. So you can see here. So you have to go for urgent 2D echo and surgical review for resecting that carcinoid in the heart. Question number 20, last but one. Cardiac tamponade, another complication in the cardiology ICU. 66-year-old male smoker while driving car had head-on collision with a truck and sustained blunt chest injury, admitted to the ED with shock. And in the echo, you are getting all these findings. So what is the differential diagnosis of echo finding and what is the treatment? So differential diagnosis, ventricular rupture, aortic dissection, pericardial effusion with tamponade. What is the treatment? To start with tapping, thoracotomy, and repair. So if it is not amenable to the conservative management. And the last one, heart block. It's not blocking our heart. We are like almost middle of our discussion, but just to provide you the ECG from so many the different domains, so that you will be clear that the question should be starting with one ECG and other corroborative findings or some hemodynamic monitoring findings. 70-year-old man presented with dizziness and near syncope. Everybody knows it. It's just a very easy like ECG. You can see what is happening. I would be giving you the clue. ECG diagnosis and treatment. So for you all to understand, PPP, you can see here. So this is AV block second degree Mobitz type 1 Wenckebach phenomenon. You can see type 1 often not necessary treatment, and this would be resulting in bradycardia leading to hypotension occasionally. But if hypotension and bradycardia occur, so as it is type 1, it responds well to the atropine. And you can, if it is unresponsive, then you can try with the transcutaneous or transvenous pacing. And if the patient is on any beta blockers or calcium channel blockers or digoxin, so those should be reduced first or medication should be discontinued. And all these patients should be admitted and monitored. Unlikely Mobitz type 2, that these patients require transvenous pacing until you are like finalizing with the permanent pacemaker. So unlike Mobis type 1, the type 2 patients are bradycardic and hypotensive, and they would not respond to atropine. So definitely you should think about seriously going for transvenous pacing. So with this, we come to end of the CBS 21 questions. Almost 1 hour we have finished. So anything at this point of time, Dr. Ramanathan? Or any of the candidates? They want to, yeah. So Dr. Ramanathan had some call in the hospital, so he had to leave. So anything, the candidates, how did you find the questions? Any response in the chat box? Anything you want to just 1 minute break? Then we would be starting with the CCS. Anyone who wants to share anything in the chat box? The type of questions, the coverage of cardiology domain, and the level of questions, or anything else? Or you are all clear in your concepts before? Hypothermia, yes, VA ECMO, as it is rising right now, every center is having like the VA ECMO more frequently. So maybe I would go for VA ECMO, as Dr. Ramanathan has also mentioned. CBS question. CBS one question, can't we go for thrombolysis or PCI? Thrombolysis, because most of the centers are very well versed. PCI would may take some time. So to just save the time and the patient's urgency, we can go for thrombolysis in the first instance and then plan for the PCI. Is atropine an option in complete heart block? They will not respond complete heart block, preferably. So yeah, Osborne, if you don't remember, you can say ECG of hypothermia. You can. So it's a name only. So hypothermia, the cause etiology is hypothermia. Yes, you can get the answer like full mark. Yeah, PTCA. Yes, you are right. Yeah. So I think most of the questions are clear. If you all agree, we'll be starting with the CCS. Are we ready to go? Because it will again take 1 hour. Yeah. Perfect. Look, the answers that we are putting, it's not that 100% what we are like mentioning would be also mentioned in the examiner's the answer sheet. It's the most appropriate answers that you are actually mentioning at that point of time. So always have a structured answer, the format or template in your mind. And if you go in that line, what we normally mention in our approach, so you will be almost 80% time you would be having the answers in your discussion. It may not be always the first one, but the second, third, what you are uttering, that would be containing the answers. The examiner would be very happy to give you a full mark. So that is the point of analyzing the question, trying to reach one conclusion, and scanning the questions, important clues what the examiner is trying to provide you, so that you can easily understand in the short time. Because whatever we are discussing, it is only 1 minute. In that only you have to pick up the clue, you have to frame your answer, understand the question, and then again comprehend in your answer. It's not that you will be only telling Osborne J wave. No, it's not the full answer. So they would be expecting that you will be also telling about 2 or 3 other etiologies. If the question is what are the other causes, what will the management? So you have to frame the sentences as well, and everything would be taking less than 2 minutes, because there would be almost 10 to 12 questions in again 10 to 12 minutes. So, and if you are missing 1 or 2 questions, the stress level is actually rising in your brain. So it won't be possible to give 100% when you are attempting the seventh number question, eighth number question. So something or other is going on in your mind, that you have missed the third number question. maybe the answer was type 1 Wenckebach phenomenon. I have told type 2 like no, the heart block, something like that. So the confusion would be also building up. So many things you need to keep in mind, and you have to maintain your cool throughout the examination process. That's why CBS, the clue, keep your calm and practice lot of questions beforehand, so that in the real exam you won't be stressed during your 1 hour non-stop exam, or maybe 45 minutes of non-stop exam. Clear? Short answers. Yeah, visible. It won't be detailed answer because you will not get time. Maybe 1 or 2 questions you can answer detailed, but after that it has to be short only. Primary PCI, but yes, look how the examiner is framing the question. You cannot the put your answers. If the examiner wants to know about the mechanical, like as Dr. Ramanathan has also told, there are multiple wings to the questions, limbs to the question. So if they want to know about the iono pressure, what is the best one, after that the question answer should be also different. Then if they want to know about the standard management by PCI or surgical at that time, that is again another limb. If they want to know about the mechanical assist devices, then that is again another limb. So it won't be right now prudent to tell that this is the protocol the examiner would also follow. Right. So that's why remember all the things and try to give the most sensible answer at that point of time. Okay. So without wasting further time, let's start with the CCS. Okay. Perfect. You all are able to see the screen. Okay. So the first CCS, what we have shared with you, you attend an emergency call in your hospital's acute medical unit during daytime hours. On arrival, a 34-year-old female, Mrs. XYZ, appears tachypneic, respiratory rate 30 breaths per minute with oxygen saturation 96% on 15 liter per minute oxygen therapy. She is tachycardic at 110 beats per minute with blood pressure of 120 per 70 millimeter mercury. She is febrile with a temperature of 38 degrees centigrade. Mrs. XYZ is alert and able to answer questions appropriately, but finds it difficult to complete the sentences due to breathing difficulty. She complains of left-sided chest pain that came on abruptly, which is affecting her ability to take deep breaths, and a swollen left calf that is painful on palpation. Now, measures to stabilize XYZ have already been initiated. This is the ECG finding. This Okay. Now this is the other two static, the echo finding, right? Very classical echo finding. Now, what could be the most likely causes of deterioration in this case? This is the question number 1 to the clinical vignette 1. So the first clinical vignette will be given to you beforehand, maybe 5 minutes before you start the discussion. Now, after that, as you answer, there would be the clinical vignettes, just like this question. So you will not get that time to frame your answers, scan the important things. So you have to be ready with your answers. So what could be the most likely cause? As we already discussed in our initial introductory the webinar also, always have a structured approach. Always have a structured approach while you are answering this type of question. What could be the most likely cause? Respiratory, cardiovascular, others. In respiratory, pulmonary embolism, the most important that is coming in your mind should be coming as the first answer. Pneumonia, acute asthma exacerbation, spontaneous pneumothorax. In cardiovascular, acute myocardial infarction, acute pulmonary edema, aortic dissection. Others, gastrointestinal perforated viscous, acute pancreatitis. So they will be framing these marks depending upon the number of options that you are actually giving correctly. So you should not be bothering about what would be the full marks in that question. But I'm just giving you a clue that there would be 4 marks. Any plausible cause, but it must include pulmonary embolism, acute pulmonary edema. Clear? So whatever you are telling, it would be giving you at least 4 marks. But if you are not answering pulmonary embolism and acute pulmonary edema, maybe you can like answer all these 10 causes, but you will get only 1 mark or something like that. But if you are answering pulmonary embolism and acute pulmonary edema, they may give you 4 marks out of 4 marks. So that is something is not very clear. It is not possible to give you exact the exam the mark how they the assess and they just give you the marks. What is the most probable diagnosis in this case? Acute pulmonary embolism, very clear. How do you define hemodynamic instability in acute high risk pulmonary embolism? Again, the answer should be very typical: cardiac arrest, obstructive shock, persistent hypotension. Cardiac arrest, we all know clearly. Obstructive shock, if the systolic blood pressure less than 90 millimeter mercury, or you are requiring vasopressors to achieve systolic blood pressure of 90 millimeter, despite adequate fluid resuscitation and evidence of end organ perfusion. Persistent hypotension, if systolic blood pressure is less than 90 or systolic blood pressure decrease of 40 millimeter mercury that lasts longer than 15 minutes and is not caused by new onset arrhythmia, hypovolemia, or sepsis. Classical. So you cannot change these definitions. So this is as per the standard, the acute pulmonary embolism high risk category. What are the other risk factors that increase your risk for VTE? Genetic risk factors, acquired risk factors, ICU related risk factors. So as we always tell to you, the candidates, always have some structure when you are answering. Don't start from here, then add up from here, then add up from something else. As the examiners would be also guessing that this candidate is not very thorough or not very confident of what are the risk factors, because it's a very usual topic in our training period. So it should be flawless in your answer style. Genetic risk factor, acquired risk factors, ICU related risk factors. I'm not going to detail. This is a very classical thing. What role does echocardiograph have in the workup for diagnosing PE? Again, straight question. Answer should be straight. Diagnostic modality, management decision. Diagnostic modality, rapid bedside assessment in a hemodynamic unstable patient where CTPA cannot be done. Clear. You can also exclude some coexisting other cardiac abnormalities like LV dysfunction, valvular abnormalities such as TR, pulmonary pressure, volume status, because that is also having some correlation with your management strategy. Now, the second big thing is management decision, whether your patient is having RV dysfunction on the echo. So, and also you need to think about whether you have to go for thrombolysis. So, all these manage echo to suggest diagnosis of P. Very classical question. Decrease in our this today echo finding. Distended non-collapsible IVC and 60 by 60 sign. 60 by 60 sign, they may ask you what is 60 by 60 sign. So you are getting two things. your pulmonary artery systolic pressure less than 60 millimeter mercury on the basis of tricuspid regurgitation jet velocity and pulmonary acceleration time RBOT, the right ventricular outflow tract acceleration time less than 60 millisecond. So that would be two things 60 by 60, 260. So this is the 160. You are getting the tricuspid gradient plus right atrial pressure. If both is less than 60 milliliter mercury, that suggests acute pulmonary embolism. And the pulmonary acceleration time in this, you are getting the pulmonary vein, and you are getting the this one, and it is less than 60 millisecond. That again suggests acute pulmonary embolism. So this is 60 by 60 sign. Coming to the vignette 2, XYZ begins to deteriorate and she appears drowsy. Now she has sustained hypotension 80 by 40 despite you have given fluid bolus over the past 20 minutes. You did the focused echocardiography that confirms the presence of dilated RV with impaired systolic function with visible mobile thrombus, as we have seen. Her arterial blood gas demonstrates pH of 7, PaO2 6 kilopascal, PaCO2 11 kilopascal, bicarbonate 11, lactate 7.4, potassium 5.1. The chest radiograph appears normal. One clue here, in the examination, they can give you in millimeter mercury or kilopascal. So you need to remember how to convert it because these are some of the basic things that needs to be converted immediately if you are getting the value. You may not always demand that why this is not given in the millimeter mercury. That also is one clue that I want to share. Gas, blood glucose, some of the other the important things that you need to remember by heart. So this is the thrombus that I am able to see. Now, what are your immediate concerns after shifting to the ICU? Intubation, mechanical ventilation, hemodynamic stabilization with titrated fluids or vasopressors, advanced hemodynamic monitoring, plan for definitive management, risk stratification, suitability for thrombolysis versus catheter directed therapy, or only anticoagulation. So some of the things that I would be deciding at the bedside after shifting to the ICU after stabilization with the immediate measures. What ECG abnormalities are associated with poor prognosis in patients diagnosed with PE? Tachycardia, which is the most commonly found ECG abnormality, sinus tachycardia. New and complete RBBB, atrial arrhythmias, for example, atrial fibrillation, ST elevation in AVR, S1Q3 T3, anterior ST segment changes, and T wave inversion. What is the rationale for ordering a chest radiograph? To investigate other causes for this presentation, and we all know it may appear normal in up to 1/5 of patients. Now coming to the vignette 3, following the uneventful or successful intubation, XYZ is placed on the ventilation with aim of avoiding high plateau pressure, standard practice. Central line is placed, noradrenal infusion rapidly rises to 0.6 mics per kilogram per minute. After 30 minutes following intubation, her BP still 1. Now she is now more tachycardic at 130 beats per minute. On clinical examination and bedside lung ultrasound, there is no evidence of pneumothorax. Urgent CTPA done, which revealed massive pulmonary embolism with evidence of RV dysfunction. Clear? So now the essence of this clinical vignette that you are dealing with lysis or embolectomy. So if there are no clear contraindication to thrombolysis, who have clear contraindication to thrombolysis, emboli can be removed surgically or using catheter directed. So this is the two things that you need to answer. What are the absolute and relative contraindication to thrombolysis? Again, I am not going to just utter these words. You need to remember what are the absolute, what are the relative. At least 4 to 5 absolute, 4 to 5 relative, if the question is asking about the same. Coming to the vignette 4, the decision is made to administer Altiplase. She has urgently received initial 10 milligram bolus over 1 to 2 minutes, followed by a 90 milligram IV infusion over 2 hours. She was continued on high dose noradrenaline and adrenaline infusion. Patient was oliguric on admission, which progressed to anuria, metabolic acidosis with rising lactate. You started thinking that sodium bicarbonate can help at that point of time. So you started on CBBSD, continued cardiogenic shock and lack of lactate clearance and hemodynamic improvement is not there, and the patient has landed up in MODS. All these things prompted to initiate peripheral VA ECMO. So the CBS question also was asking that, and here also in the CCS also, the question landed up in the clinical vignette 4 in the VA ECMO. You can see now it is gaining so much popularity. You need to remember, understand the concept behind all these things. Here, thrombolytic therapy is again cardiac pharmacology. You need to remember what are the thrombolytic therapy, what are the adverse effect, what is the dose, and what is the management of cardiogenic shock here again is asked along with the CBS. Now, one clue I want to highlight here. In the CCS clinical vignette, if you are not mentioning thrombolysis in the question number 10, and after one question in the second, the next clinical vignette, if you are getting the answer which is a thrombolytic, or it is mentioned in the thrombolytic, that means you have entered into a wrong track. So the examiner would not be very happy that you have missed something. On the basis of that treatment modality, the next clinical vignette is started. So I hope you are getting my point. If the next question, if it is nephrocritical care and the answer the examiner expected from you is something related to renal replacement therapy, but you have not mentioned that renal replacement therapy, but the idea of renal replacement therapy, but you are still continuing with diuretics or fluid resuscitation. And the next clinical vignette is actually highlighting the importance of renal replacement therapy. That means you will be losing, I think, bulk of the marks, despite you are answering that particular clinical vignette on renal replacement therapy. I hope I am clarifying you a very important clinical note at this point of time in our debrief. What are the indications of VA ECMO in general? Again, I'm not going to highlight cardiogenic shock, cardiac trauma, post-cardiotomy, bridging therapy, drug overdose, anaphylaxis. You need to remember and answer it on the basis of the question. What are the unique complications with VA ECMO? Here it is a little bit difficult, but I would be highlighting or emphasizing VA ECMO is something which is very burning topic. So you need to go in detail of the complications of VA ECMO. Here the examiner expected that you are telling about limb ischemia and LV distension. Those people who are working in ECMO compatible or ECMO feasible centers, they know what do you mean by LV distension. What is LV distension? As VA ECMO can increase the LV afterload, and a low LVEF can lead to LV distension. So there would be like some amount of blood which is actually accumulating in each time the heart is pumping against the afterload. How do you detect it? Frequent echocardiography. You will see that the aortic valve is not opening. You will be doing chest X-ray where you will be getting the pulmonary edema in the chest X-ray, enlarge the heart border. You will get, if your like patient is having PA pressure like catheterization, so you will get increased wedge pressure and PA maybe is the contractility, diuresis or ultrafiltration, IABP, catheter-based pump, creation of atrial septostomy, or surgical LV venting. If you are still, after all these conservative managements or minimal invasive management, if you are unable to decongest your LV, so you will be directly, like the surgeon would be directly doing one like stoma, or like I would say something like opening, so that your LV is decongested at that time. Now, what are the major advantages and disadvantages of thrombolytic therapy in acute PE? Again, I am not going to detail. You can mention in these following terms: hemodynamics, accessibility, and bleeding. It would improve immediately the pulmonary artery blood pressure, RV function, and pulmonary perfusion. This is one of the most widely used and available and easy to administer. Maybe VA ECMO would take some time to implement, so it would be not always available in most of the centers, and the expertise and the teamwork has to be there. And the bleeding part, the opponents would always say that anticoagulation therapy, the systemic thrombolytic therapy increases the risk of major bleeding and intracranial hemorrhage. But in high risk patients with cardiogenic shock, with pulmonary, the cardiac thrombus, the benefit of thrombolysis in reducing the combined outcome of mortality and recurrent P appears to outweigh the risk of bleeding. 9.9 rate of severe bleeding and 1.7% rate of intracranial hemorrhage. So you have to take the risk and start the thrombolytic. Coming to the vignette 5, patient vasopressor requirement started to downtrend. Patient started improving 48 hours post commencing VA ECMO. On day 3, something atypical happened. The SpO2 of right arm dropped to 88% and arterial blood gas from the right radial artery confirmed PaO2 of 45 only. The SpO2 from other extremities were normal. Chest X-ray demonstrated right upper limb atelectasis. Echocardiogram showed improvement of LV systolic function and well opening of the aortic valve with your all management for the LV distension. So what is happening here? What is the complication? What is the mechanism of such a complication? So this is Harlequin syndrome. I am dealing with at this time peripheral VA ECMO. Saturation of the upper part of the body is lower than the lower half. This is due to flow competition in the aorta. As with the ECMO, the heart is right now recovering. So heart is trying to propel the blood forward, but the ECMO is trying to also like giving you the support. So there is the mixing of the decongested blood with the pure blood. So this is something happening like this. So there is a watershed area. So this is also called as north-south syndrome. Something coming from the south, something coming from the north, both are mixing, and it mixes, or the watershed area is the upper limb. So that's why you will get the decongested blood, or the blood with PaO2 low in the upper limb, right upper limb. So this situation specifically occurs when the native LV function improves and competes with upcoming stream from the femoral cannulation. The battleground is drawn somewhere in around aortic arc. It is a fight between the stroke volume from the native LV and the ECMO return. So you need to go in detail of this Harlequin syndrome. How will you troubleshoot this condition? By increasing ventilatory management. Still, you need to continue with the ECMO. Think about putting the cannula in the axillary or carotid. If heart has recovered, decannulate, convert to the VA-V ECMO, and think of other mechanical circulatory support system like Impella. So these are some of the troubleshooting. What are the major trials on the VA ECMO as eCPR, ARREST trial, CHAIR trial, eCPR for refractory out of hospital cardiac arrest, Prague OHCA study, that is out of hospital cardiac arrest, and Inception trial. I'm not going into detail, but these are some of the standard landmark trials that you need to remember for eCPR, the role of VA ECMO. Now coming to the vignette 6, on stopping sedation. Now from the cardiology, the patient is entering into the neuro. So this is the classical CCS. They will not follow or restrict themselves to only one domain. Now, on stopping sedation, the patient was not waking up properly or appropriately and had upper motor neuron sign. CT brain was done and you are getting the CT brain finding. What are the risk factors for ICS? This patient is having intracranial hemorrhage. For ECMO patients, so some of the things that you need to remember if you are putting the patient for long time on ECMO, rapid hypocapnia. So there will be vessel rupture in the like no, intracranially. PaO2 increase at ECMO initiation, female gender. If the patient is having pre-cannulation SOFA score to be very high, associated septic shock, pre-ECMO morbidity is very high, platelet is very low, and you are using heparin to high dose in the ECMO. So these are some of the risk factors for ICH in ECMO patient. What is the mechanism of ICH in ECMO patient? Low as the typical, we all know why ICH happens. So that the same physiology would be also applying here. Low cerebral blood flow, hypoxia, acidosis, reperfusion injury if you are putting the patient on ECMO, rapid shift of PaCO2 and PaO2 leading to the vasoconstriction, and thrombocytopenia, anticoagulation, and there is also pre-existing anticoagulation in that patient due to the thrombolytic use previously. So these are some of the risk factors or mechanisms of ICH in ECMO patient. Now, there is another like important thing we have already discussed in our CBS also, mechanical circulatory assist devices. So they may ask you what are the right ventricular support, what is the left ventricular support. So this is a picture. Right ventricular support are the impella and tandem heart, and left ventricular support via ECMO, IABP, impella, tandem heart. Not going into detail. Now, the last vignette in the CCS1, on day 5, patient was decannulated successfully. Sedation hold for 48 hours. His GCS is E1, VT, M2. His kidney functions have improved. His current urea creatinine liver function tests are within normal limit. He is making 30 to 50 ml of urine per hour. His last fentanyl dose was 48 hours ago and he has been off propofol since. The patient's bedside nurse reporting that patient is having tonic roving movement of the eyes and his electrolytes are sodium 148, potassium 4.8, magnesium, calcium, phosphate are within normal limit. His ABG is okay. He has no neck stiffness. He has been afebrile for last 48 hours. What is happening? What is your differential diagnosis and what is your provisional diagnosis for his encephalopathy? Non-convulsive seizure should come as the first answer. Progression of IC bleed, any other IC event that has happened, new ischemic stroke or subarachnoid hemorrhage. So out of these, you should be restricting yourself to the DD. How will you further evaluate? EEG should be the first one to exclude the NCSE. Rule out if you are still giving or the patient is having some potential drug causing encephalopathy. You can repeat one CT brain to check that ICH has not progressed or any new event has not been like right now occurred. Repeat electrolyte, check the sodium level, rule out any other metabolic factors like high ammonia. In the context, if the patient is on sodium valproate, it would be causing hyperammonemia. So you have to exclude that part and other drugs if patient is having still now. How will you treat this patient? Midazolam or lorazepam. Continuous EEG monitoring has to be done to like check burst suppression. Load with Levipil. If still the patient is having seizure on EEG, you have to add phenytoin or valproate. Target should be burst suppression on the EEG. And you should prefer at this point of time continuous EEG. What is the like prognosis if your patient is having non-convulsive seizure on the morbidity and mortality compared to the convulsive status epilepticus? Non-convulsive seizure if your patient is having longer length of stay and mortality is actually more or worse compared to the convulsive seizure. So if it is NCSE, definitely it's not a good prognostic marker for your patient. Thank you. So at this point of time, we are finishing the CCS1. CCS2 is a shorter one, but it is very atypical. I have got this recently in one of the articles, so I thought of putting that to just like brush up that in the EDIC 2 exam, they may come up with some innovative clinical cases, some of the things, some recent advances. So let's start with 38-year-old female, a software engineer by profession, was admitted to the emergency room with symptoms of diarrhea and vomiting. We started 48 hours prior and progressed into an unproductive cough and dyspnea. Just go through and scan the important points as I have highlighted before. 5 hours after admission, her hemodynamics worsened further and she developed acute respiratory failure. Vasopressor in the form of NorEpi was promptly initiated and the patient underwent ET tube in place and mechanical ventilation, followed by shifting to the ICU. Patient was kept on with sedative analgesic and intermittent neuromuscular blockade. Now, in her previous history, no recent flu-like symptoms were recorded, and patient has received 3 shots of COVID-19 vaccine. A large consumption of alcohol and electronic cigarettes in the 48 hours before the first symptoms have been reported. What is going on in your mind? If somebody has not attempted this clinical vignette in the last few days when we have shared the test link. So what is happening here? 38-year female software engineer, sudden onset of diarrhea, vomiting, then unproductive cough, dyspnea, shifted to ICU, patient have hemodynamic instability. But the history is something very strange and something they have categorically placed electronic cigarettes. Maybe I am dealing with something related to electronic cigarettes. So this is the X-ray. So differential diagnosis, chest X-ray finding, and further investigation that I need to do. So again, the answer should be always in a structured fashion, infective versus non-infective, pulmonary or cardiac or others. We have already mentioned in the CCS1. So infective or non-infective, pulmonary, cardiac. In the infective pneumonia, again, pneumonia can be bacterial, viral, COVID, influenza. In the cardiac acute coronary syndrome with pulmonary edema, pulmonary thromboembolism. In the X-ray, the finding is bilateral diffuse pulmonary infiltrates. In the CT, I'm just highlighting here itself, though the question was not there. You will get diffuse bilateral ground glass opacities with basilar predominance and sometimes subpleural or lobular sparing. What are the investigation that we will do? 12-PDCG, ABG, complete hemogram, cardiac enzyme, HRCT thorax, focus, 2D echo, PAL, diagnostic or therapeutic, CRP, procalcitonin, urine tox. As the patient was found to be having, the question is itself, alcohol and electronic cigarettes. And the most common thing that you will be suspecting if your patient is having electronic cigarettes consumption is any smart answer? Tetrahydrocannabinoids, THC. Okay. So coming to the Vignette 2, laboratory tests initially indicated metabolic acidosis with increased anion gap, hyperlactatemia, and PaO2 FiO2 ratio of 220. Bedside ultrasound was performed, significant LV systolic dysfunction, and IVC variability greater than 30%. EKG study done that showed sinus tachycardia. There is no suggestive acute ischemia. Other laboratory findings demonstrated ultra-sensitive troponin 496, hemoglobin 13.5, TLC 7400, 70% neutrophils. Other relevant findings, elevated CRP, mild hyponatremia, hepatic and renal function were preserved. Tracheal aspirates came to be negative. CT thorax done that showed this one. Clear? Now, Don't go with the image. This is just showing the clinical diagnosis that I am dealing with. What she is using? This is electronic cigarette. 34-year female. She is not the patient. It is E-Valley. I am dealing with E-Valley, though it's a very new terminology, but I thought of like putting this as a question to highlight that this type of syndromic or something new can come up in your exam. And here I am talking about cardiology, but why I am going into the respiratory part? Somebody may be asking at that time when I just started with the respiratory problems. The question is going to unfold. Don't worry. In the next, it will come to cardiology. So believe in me, this is a cardiology domain only. Now, what is E-Valley? E-Valley stands for e-cigarette or vaping use associated lung injury. So it is E-Valley, or before it was Valley. So we heard about Valley. Now there is a terminology Valley, but to just make it less confusing, the new terminology is right now more popular. It is E-Valley, e-cigarette or vaping use associated lung injury. What are the diagnostic feature of E-Valley? Before that, it was previously known as VAPI. I have already told. Vaping associated pulmonary illness or lung injury. The new name is in response to a growing number of severe lung illness cases related to using e-cigarette or vaping products, the first being identified during 2019. Vitamin E acetate, this is the culprit. And in the e-cigarette or electronic cigarette, this is one of the additive. And sometimes they also use THC containing e-cigarettes, that is tetrahydrocannabinoid, as the primary, but not the only cause of E-Valley. There is no single test for E-Valley. Diagnosis is mostly a process of elimination because symptoms can be similar to many other respiratory diseases. COVID, influenza, bacterial pneumonia, anything like that. You have seen the chest X-ray, you have seen the CT thorax. It is not a very specific to E-Valley. Now, what is the definition of E-Valley or VAPI? Acute or subacute respiratory illness characterized by spectrum of clinicopathologic findings mimicking various pulmonary diseases. According to the CDC criteria, E-Valley is a clinical diagnosis that requires the use of an e-cigarette in the 90 days preceding the appearance of initial symptoms, pulmonary infiltrates on a plain chest radiograph, as we have seen in our patient, or chest CT, and absence of any other possible etiology such as infection. So this is the definition as per the CDC. Now coming to the Vignette 3. Repeat echo done by ICU specialist that showed significant impairment of LV systolic function with an estimated ejection fraction of 20%. You are still confused that patient started with respiratory problem. Now the echo is showing low ejection fraction. What is happening? So you have decided to put one pulmonary artery catheter, and that showed normal right atrium and pulmonary artery systolic and diastolic pressure, but increased PCOP or PCWP, increased pulmonary capillary occlusion pressure. Central venous oxygen saturation 75%, lactatemia 4.5, repeat troponin is also still very high, 482. This is the echo finding. You did the echo, and this is the echo finding you are getting. Now, any smart minds at this point of time, what is happening? Anyone was attempted, was not attempted by looking at the clinical scenario? Cardiology opinion was taken. Yeah, somebody has mentioned something. Yeah, stress cardiomyopathy. Very good. Very good. My job is, I think, done. What I have tried to mention in my CBS also and CCS also. Look, in the first CCS, I started with cardiology, landed up in the neurology or neurosurgical. This one, I started with pulmonology, but landed in the cardiology. So CCS is never predictable. This one I want to highlight in this first domain of our discussion. So you will be completely taken to north. Immediately the examiner would like no just pull you from north and put you in the south. So believe me, you will be confused. What is actually the examiner's intention? To pass you, to fail you, or to hang you in between. So cardiology opinion taken. What is the provisional diagnosis? I'm just making it a little bit faster so that we can complete it. Cardiogenic shock in the context of reverse or atypical Takotsubo cardiomyopathy and E-valley. Don't go with this reverse or atypical. I would explain you. But if you are mentioning Takotsubo cardiomyopathy or stress cardiomyopathy, you will get full marks. This is something very atypical. So that's why I have taken it. Why do you think so? Moderate impairment of the global systolic function, ejection fraction is 25%, relatively preserved apical segment, and markedly reduced mid-basal segment. Normally, in the typical Takotsubo cardiomyopathy, you will be remembering I have mentioned in my CBS typical, atypical. So, what is this typical? Typical is there would be the basal level would be relatively preserved function, but the apical segment would be reduced. But in the atypical or reverse, it would be just the reverse. That means the apical segment would be preserved, but the basal segment would be reduced. Use of electronic cigarettes increases the risk of both myocardial infarction and stroke. So that is acting as a stress, and also simultaneously respiratory failure has happened, and that both the two things have precipitated the typical Takotsubo stress cardiomyopathy. What are the pathophysiologic mechanisms? The pathophysiologic mechanism, we all know it's a central sympathetic storm. And a lot of things happen, multiple vasospasm, inflammation, stress due to nitroactive. Then there would be a metabolism altered with intracellular lipid accumulation, microvascular dysfunction, peripheral sympathetic storm, surge in the ventricular afterload load. So many things are happening. Please go and read the detailed analysis of the Takotsubo cardiomyopathy. It is one of the high domain. What are the etiologic risk factors? The prevalence, why it is increased in the female patients. What are the physical triggers? What is the emotional triggers? What is the primary TTS? What is the secondary TTS? All these things are very important. Primary is emotional. Secondary is there would be physical triggers. No, coming to the treatment part, no RCT has been done till today that supports specific treatment recommendations for Takotsubo syndrome. If somebody is asking what is the definitive management, till now nothing is clear. There are certain principles behind the treatment of Takotsubo syndrome. First one, primum non nocere. That means do no harm. Just hold on. Keep your cool. Maintain the hemodynamics. Give supportive treatment. The major objective should be supportive care to sustain life and to minimize complication during recovery. In mild cases, no treatment or a short course of limited medical therapy may be sufficient. The prognosis is very good. Treatment, maybe you can start with inopressors if you're dealing with low ejection fraction. In severe cases where you are still getting progressive circulatory failure and cardiogenic shock, early mechanical support should be considered as bridge to recovery. And the patients who have significant LV systolic dysfunction, ejection fraction less than 40%, you should be trying with S inhibitors and beta blockers. In the beta blockers, carvedilol is the preferred beta blocker unless there is no significant LV outflow tract obstruction. If you are having LV outflow tract obstruction, then beta 1 selective beta blocker should be preferred like bisoprolol. Both S inhibitors and beta blockers can be weaned off if your patient is improving, your LV function is improving, and there is no other indications to continue with S inhibitors or beta blockers like tachyarrhythmias or hypertension. Coming to the last clinical vignette, diagnosis of cardiogenic shock in the context of reverse or atypical Takotsubo cardiomyopathy and E-valley was made. Patient gradually required increasing dose of vasoactive drugs in the context of increasing dose of vasoactive drugs. Evidence of worsening LV systolic function. Dobutamine was started. We all know that is the inotrope of choice in Takotsubo cardiomyopathy. or cardiogenic shock. After inotropic infusion started, patient demonstrated marked improvement of the ventricular function. Now you gradually reduce the dose of dobutamine and later norepi and vasopressin. You repeated the HRCT thorax and 2D echo, and you have seen marked reduction in the bilateral superior and medial ground glass infiltrates, and echocardiography also from the 25% jumped to 52%. Significant improvement in the ventilatory parameters were also observed, and PO2 and FiO2 is from 220 to 400 only 48 hours after ICU admission. So that gives you the idea that the recovery, the prognosis is very good if you are supporting it very well. Given the hemodynamic and ventilatory amelioration, patient underwent spontaneous breathing trial, subsequently extubated. There is improvement in the hemodynamic and respiratory status, and patient is shifted to the HDU. Now, the last question, maybe they would be asking what is the prognosis of Takotsubo cardiomyopathy, what are the follow-up modalities in Takotsubo cardiomyopathy and E-Valley. So prognosis is very good, excellent. You have to avoid the etiologic factors. You should not, you should counsel the patient that you should not repeat with the e-cigarettes, and you have to follow up with 2D echo and pulmonary function test. You will see that there is no restriction of the vital capacity and also the functional residual capacity. Thank you very much. With this, we come to end of this elaborative discussion on cardiology. So we have touched upon, I think, most of the important domains that can be asked in the cardiology side. And if there are any questions, I would be very happy to take. And please share your feedback. How do you find the discussion? And anything you want to get in the subsequent domains. I have tried to give you something about everything. I know there are certain atypical questions you would feel like this type of questions will not be asked. Believe me, it is not like that. The examiners are sometimes very fond of asking some atypical questions to get the best ones out of the lot. So you will be in that range of 80%, 90% to get the toppers or something like that. So for them, I need to have something. It should not be very easy also. And as I always emphasize, it is better to sweat in peace than bleed in war. So thank you very much. We will be sharing you the recorded version. Don't worry. And if somebody of you wants to join our course, register our course, please feel free to contact post in the WhatsApp group. And the course has just started. This is the first domain, and you will get this type of extensive discussions in every week. And I think that is needed. You all know we want to just polish you something before the examination so that you look fresh, you look confident, and the rest, I think God is great. Thank you very much. I wish you all the best and keep in touch. We will be ready to help you. And please share your feedbacks in the social medias also and also in our WhatsApp groups to make us motivated to prepare this type of rare questions for you all. Take care.